Hello and welcome to Two Peds in a Pod, the Paediatric Medical Education Podcast. Remember, you can hear our entire back catalogue of episodes on iTunes, Spotify, Google Podcasts, Amazon Music, and of course, our SoundCloud. So please tell your colleagues and friends and hit that subscribe button. I hope you enjoy today's episode. Hello and welcome back to the podcast. I'm your host, Ian Lewins, Paediatric Emergency Medicine Consultant based in Derby. And today, I'm very pleased to say we've got a dentistry special as we're joined by Jessica Talbot and Lucy Brown, who are both specialist registrars in paediatric dentistry based up in Hull and Leeds. Good afternoon, how are you?
Good, thank you. How are you?
Yeah, very well, thank you. So it's really nice when people contact us to say, "Oh, we'd like to come on and chat about stuff." Why did you get? I guess my first question would be, why did you get in touch? What do we? Dentistry. That's totally separate, alien country to us in paediatrics. So why did you get in touch?
So I have recently completed my fellowship. So I was actually using your podcast as revision on my long drives to work. And I suppose having done multidisciplinary teaching course recently, I've become acutely aware that lots of doctors do find dentistry a really alien topic and often ask me questions that we would consider to be relatively routine or day to day. And so I think as a specialty now, paediatric dentistry are getting better at trying to use platforms and highlight some of the issues that we're having and how we can work with our medical colleagues to do it. And so the podcast just seemed like a good platform to approach, really.
Yeah, and I was just thinking about my sort of medical training and dentistry and oral health. And I'm really struggling. There's a distinct possibility I could have been asleep in the lectures, but I really struggled to sort of think of what training I got in dentistry and oral health at medical school.
Yeah, I think my understanding from the colleagues that I had when I was at university is that unfortunately it is relatively limited. I know the Chief Dental Officer for England is keen and promoting at the moment putting the mouth back in the body, and I think that probably needs to happen from medical school onwards to help in the future. And I know definitely there's probably moves towards that, but I think it's kind of dental needs to take responsibility for it as well as it coming from the medical profession to try and ensure that there's perhaps greater understanding across the board.
And I think certainly in paediatrics, it's something that we recognise is maybe we've been sort of overlooking dental health and oral health for quite a while, and it's gained a bit of prominence and a bit of traction at the moment. And we'll come on to those. But I guess the first thing I'd ask you guys about is, I guess the commonest thing that I might see in my practice in the children's emergency department is the avulsed tooth. And I've kind of got in my mind what advice I give to parents and families if a tooth comes out. And I think I've got it right. But what advice do you give to parents? So if a tooth gets knocked out at home, what do you say to them to do?
So the first thing we would say is put the tooth back in. Whatever circumstance it is, put the tooth back in the socket. And we kind of say the scooped out bit, as Lucy aptly described, the scooped out part goes by the palate. So the smooth bit goes by the lip. And that is all that you need to do. And then head to A&E. Well, you're in A&E, to the dentist. But the most important thing is to get it back in, because the longer that you leave it outside of the mouth, the poorer the prognosis is. If you can't get it in for any reason, if patients are really uncooperative, there's lots of swelling, you don't feel confident, that's okay. But we want to store it. So the key is that we don't want to leave it dry for too long, because then the cells on the outside of the root start to die. So storing it in something like milk is always great. We store it in... Alternatively, it can be stored in saliva. And as a last resort, water, although that would never really be the recommended storage medium.
Yeah. So,
and then
sorry. Yeah. So milk is the one I've often sort of. If you can't put it in the mouth, milk's not bad. Is that right?
Yeah. Milk is definitely
definitely your friend. It's the best, kind of the next best thing that you can do.
Okay. And the other thing I'm sure I've been told is make sure you try not to handle the root of the tooth as much as possible, because that sort of poorer prognosis. Is that right?
Yeah, exactly. So the cells that live on the outside of the tooth are really delicate. They don't react well to either being dry or being handled. So you want to hold what we call the crown, which is the part of the tooth that you'd see in someone's mouth, and that's the bit you want to hold as you push it back in.
Okay, so we're trying to put the tooth in the mouth as much as possible. Failing that, milk. Does it matter? Do you sort of, is there a time critical approach to this? Does it, after a certain time, you go, oh, we can't fix this, sorry?
Yeah, so it's a time critical or time dependent injury, definitely. So kind of half an hour is the time frame that we'd really love teeth to be back in the mouth within. So that's quite short if you consider, attendance at a dentist or A&E, which is why there's definitely been big public health messages for trying to get families to do it themselves. And there's a really good video on the Trauma UK website, which kind of explains how to do it. But that said, we would almost never put one back in or reimplant a tooth because there's still benefits to doing it. So it's in only a very, very rare instance where we wouldn't put a tooth back in after a period of time. So we would almost always reimplant it, but half an hour is the kind of aim, really, is for it to be back in within that time frame.
And I presume this sounds incredibly stupid again, but I presume we're talking about sort of your adult teeth. Milk teeth, we're not so worried about.
So milk teeth, the advice would be to not reimplant them, with a view that you could potentially damage the permanent tooth that was developing underneath it. Sometimes that's a bit tricky because families or doctors might not be confident whether or not a tooth is an adult tooth or a baby tooth. So normally you would expect an adult tooth to come through from the age of about 6, although that would be relatively young. I think really the take-home message should be that if you're worried that it might be an adult tooth, to store it in milk and to take it to the dentist to check.
Okay, so but baby teeth, we're not too worried about. How about if it is a baby tooth, and we often see baby teeth that have been hit or chipped, and so the tooth had kind of snapped in half. What would you do about that?
It very much depends on the symptoms, really. I think when it comes to baby teeth, particularly anterior teeth, we're not in as much of a time frame as we are with adult teeth. But I think if it's starting to cause pain, or there's predominantly straight after a trauma, you're going to get a discomfort from the soft tissues more often, and then after they've settled down, you might get some sensitivity or pain from the tooth that's been traumatized. I wouldn't be rushing to do anything necessarily in A&E when it comes to a baby tooth that's been broken.
I think it's about signposting them to go and see their general dentist. The international guidance now would really suggest a more conservative approach to injuries to baby teeth, so long as the child was managing okay and could take adequate pain relief and appropriate kind of fluid and nutrition on board. But so really an assessment by a dental professional for baby teeth in that first instance rather than anything else drastic.
Okay. And is there any, say if the child falls over and the tooth is sort of pushed upwards into the gum or downwards into the gum, is there any danger that can, if it's a baby tooth, that can impact on the way that the secondary tooth comes through?
Yes, it can do. It depends on how severe the what we call an intrusion, or like a luxation. So intrusion pushed in, extrusion pushed out, and then we also say luxation. So that's kind of in any other direction is really. But there is always a risk with movement of a baby tooth that it could hit the crown or part of the tooth of the adult tooth. And we warn parents of that when there's primary tooth trauma, and that's kind of the biggest warning really that we say when there's been a baby tooth that has been traumatized. But there's not much that we can do initially really to manage that until we see the adult tooth come through, and that's just a case of it's important in those aspects to have a general dental practitioner and be registered with a general dental practitioner so that they can monitor when those adult teeth come through, and then refer accordingly if necessary.
Right. Oh, that's really useful to know. So, okay, we've got some really good advice there. Baby teeth are not too worried about. Adult teeth, 30 minutes in the mouth ideally, or milk as an alternative. I guess the other thing, just to sort of think in terms of trauma and stuff that comes to see us, is often braces that fall out or braces that get snapped, that often come to us occasionally instead of the dentist. Is there anything in particular that in an ED we need to be doing, or is it just simply a case of contacting their own dentist or contacting the on-call Max Fax team?
Yeah, so I suppose probably the injuries you're perhaps describing come from what are traditionally called like train track braces. So they are metal brackets that are fixed onto teeth with wires in between, and they quite frequently come loose. And the trauma often comes from the wire kind of gouging into cheeks or gums. Normally, signposting them to their normal general dental practitioner or their orthodontist would be appropriate, and they should often have kind of emergency cover if that practice isn't available. That said, your helpful Max Fact department might be able to come and help and just cut wires, which just reduces the trauma. Or something really simple is just a piece of wax. And sometimes I've even known people use the wax from outside of a baby bell to stick on the end of to stop the trauma. It's relatively simplistic, but kind of quite often does the trick and just means that sharp edge won't nick in the time that it takes to be seen.
I love that. That's definitely going in the knowledge bank of cool stuff to do. Use a baby bell, right? Excellent. So I guess that's a little bit about sort of teeth and trauma. I guess also from a general paediatric perspective, the big thing that worries us and the big thing that we've maybe neglected is gum disease, tooth decay. Is that something that is as bad as we're kind of led to believe, do you think, at the moment in the UK?
Yeah, so I suppose I'll start with gum disease. So gum disease is probably a condition that's more prevalent in the adult population. So as children's dentists, we do see cases of it, but it tends to be an issue that affects the adult population more. But dental decay is very much an issue in our child population in the UK. So on a kind of 10-yearly basis, there is a children's oral health survey which looks at how many children in different age groups have decay, and we know, for example, in our 5-year-old population that nearly a quarter of them will have obvious dental decay. So it's a big issue, and I suppose more concerning, which is gaining some traction as well, is that there's a really big issue in that there's a massive disparity in different socioeconomic groups. So it's really unequal how it's distributed within kind of people and populations. And it's something that I suppose children's dentistry, through our national group, the British Society of Paediatric Dentistry, is trying to gain more press for and coverage to try and kind of increase support for families. So I know they've supported things like the sugar tax levy, etc., and are still working with the Chief Dental Officer for England and other groups to try and put other things in place.
Things like the Dental by One, driven by BSPD. They've been promoting that all children by the age of 1 should be registered and seen by a dentist. So that falls in line with what you've been saying, Lucy, about striving to push for children to be seen by a dentist so early on. And often parents don't realise necessarily that they should be seeing a dentist that young because they don't have teeth or they don't have many teeth, but it's more about establishing a routine and starting that prevention early, which is key.
And I mean, when you look at these surveys, and they are shocking results, really, is this, it's obviously multifactorial, but is this largely lack of access to dentists and sugary things in diet, poor diet? Are those the main drivers, do you think, to this?
Yeah, I think, as you said, it's there's not necessarily a simple solution, but we know that dental decay occurs when there's a kind of misbalance between how much sugar is consumed and the frequency with which sugar is consumed rather than the quantity. But we know that access to a dentist also means that children are getting dental decay young, and then it's not being treated early, and that then leads to kind of like bigger issues. So that leads to our kind of stats we've got with our 5-year-old population. So yes, it's mainly kind of dietary factors. Toothbrushing and like oral hygiene definitely affect it. We're fortunate now that most of our population would routinely use a fluoride toothpaste, but lots of the kind of key, very simple oral hygiene messages, oral health messages, aren't necessarily as widely known as we would perhaps like, in the same way that I think the general population would have a better understanding about obesity, say.
And I don't know if you know the answer to this. Does the UK perform sort of particularly badly with regards to dental decay compared to, say, the rest of Europe or equivalent wealth nations?
I think it's quite varied. I think given the kind of wealth of the UK, definitely we have issues in terms of treatment of dental decay. And I think some of that comes down to like the access that's
and also
available.
Experience. Sorry, Lucy, and also experience within. There's varied experience and confidence in treating children, and children are difficult and can find treatment quite difficult, and also access not only to the dentist but access to have that treatment. A lot of children can't necessarily manage multiple teeth out awake, so then they're having to have those teeth out under GA. And with that comes not only you need an assessment, then you're waiting for a general anaesthetic, and those lists are climbing, those waiting times are climbing. Pre-COVID they were long, and post-COVID they're even longer. So
yes, of course. And I guess this is something that there's going to be a huge backlog for you guys and a huge catch up at this point in time, isn't there?
Yeah, unfortunately there is. We know that in the kind of 7 to 9 year old group that going off to sleep to have teeth out was the most common reason for hospitalisation. So, you know, we know that nationally it's a big issue, and
over 100,000 hospital admissions for children under the age of 10 were due to tooth decay. Even though decay is almost entirely preventable, it's a vast proportion of hospital admissions are due to decay.
I mean that is shocking, isn't it? Just say that again.
Over 100,000 hospital admissions of children under 10 are due to dental decay, and of that, of at the age of 5, nearly all oral sepsis is due to decay, and 1% of children experience oral sepsis. So,
and as you say, know, entirely preventable.
Entirely preventable, yeah.
Gosh, and you know, I think when you sit down and you hear that number and you hear it's the commonest reason for a child to be admitted into hospital is something that's a preventable public health issue. We've kind of failed a bit here, haven't we?
Yeah, and I think one of the issues perhaps is that nationally it's culturally acceptable. It's almost an accepted norm. Definitely in some of the areas that I've worked in, it's accepted that children at a certain point in their childhood will go off to sleep to have teeth taken out, and
some children have you have baby teeth out at a certain age, and then they come back later and have their adult first molars taken out a few years later. So
that's seen as normal.
Not in all families, but I think nationally and potentially culturally, it's not considered as kind of shocking as perhaps it should be. And I think culturally that means that making change and kind of changing re-education is difficult, because it does appear, you know, English are always the British people are always the butt of jokes with Americans about having bad teeth, and I think to an extent it's an accepted cultural norm, which it shouldn't be.
And I guess the other we obviously don't see that so much in the emergency department, but we do see sort of a reasonable number of children presenting with swelling and dental abscesses. Is that something that you guys see a lot of, and how do you manage it?
Yes, unfortunately, it is quite a lot. We do see quite a lot of children with swelling and dental abscesses, and quite often chronic abscesses that have been present for an extended period of time. I know when we did some work in Hull looking at our children that went off to sleep, I think 5% of them had evidence of an infection. at the time of their assessment. So it's really common. In terms of managing it, depends a bit on the tooth and the child. Generally speaking, if there's infection, the tooth is likely to be taken out, and the kind of treatment modality for that would depend on the number of teeth that needed treating at the same time. And I think that's probably one of the reasons that going off to sleep to have teeth out is so common, is that we're often not talking about one tooth having decay, but about multiple teeth in multiple corners of their mouth, and therefore it's a lot to expect a child to manage that awake, and that's why our list for general anaesthetic kind of nationally can be so long.
Yeah. And whenever we see these kids, we often, we obviously speak to the maxillofacial or the dentist on call, and they always ask us to get an OPG, and I do love a good OPG because I'm always fascinated by the X-rays of the teeth coming through. It was so creepy. What is it that you're looking for? Because I look at it and go, I don't know, and then somebody will come along and go, oh, it's clearly this. What are you guys looking for on the OPG?
So we're looking at general anatomy. So from an OPT, we can see eyes, nose, antrums, mandible and maxilla, and all teeth. And then we can also see if the adult teeth and the baby teeth and the presence or absence of those teeth. So I'm sure Lucy and I probably do a very similar thing. You check all the teeth and check that there's nothing missing, predominantly kind of upper, second incisors, and second premolars tend to be, if there's going to be missing teeth, they're like the more common teeth to miss. It's not common to be missing teeth, but they're kind of the ones after wisdom teeth. And then we're looking at, now with an OPT, it's really good for kind of a general perspective of a patient's dentition. It's not that useful necessarily for seeing kind of early decay. We would take a different type of x-ray for that, but where you can see really big cavities or infection, it's really helpful. So we look at the roots of the teeth, and is there any kind of radiolucency around those roots, and that gives us an indication of the restorability, or can we save these teeth. And often if you've got kind of big radiolucencies around baby teeth roots or adult teeth roots, predominantly baby, we wouldn't try and necessarily save those teeth. We would be opting to take them out.
Right.
So they're really useful for our MaxFax colleagues if, say, they've got a child with a swelling who needs to be admitted to have that tooth extracted. We would always be keen for any tooth that had decay in it to be removed at that same general anaesthetic, to avoid them needing a repeat in the future with another episode of pain or swelling. So from our perspective, taking those radiographs is really, really beneficial and helpful.
Okay. Now, I said OPG and you said OPT, and I'm sure you're right and I'm wrong. Is there a difference between the two?
No, they're used interchangeably.
Oh, fine. Okay, well, that's good, because, I will worry about getting that wrong. Okay, that's really useful. So these are the things that I see that are sort of vaguely teeth related. The other thing that you mentioned when you contacted us was to talk a bit about safeguarding. And I was then thinking, well, what about safeguarding in teeth? So what were you getting at there? What sort of things do you see?
Yeah, I suppose we're coming at it from two angles, really. The first, from a kind of like ED perspective, would be that when they look back at children who've undergone child protection medicals, a good proportion of them have had kind of intraoral or dental injuries that have often been overlooked. So I suppose it's just encouraging people to have an index of suspicion and to think about having a brief look in the mouth or asking about dental injuries when they've got other concerns. And secondly, really, we're really proud that in Hull, where we work at the moment, there's being a kind of new pilot where we see children who are looked after children, and there's a kind of new pilot to help them access general dental practitioners. So really it's encouraging our medical colleagues to kind of work with our dental colleagues so that these children can get the best support they need and be seen appropriately, because often these children move around such a lot. They go to different foster homes or different places that often kind of their dental care is overlooked.
Yeah, it's not always the priority when you've got kind of chaos and other things going on. Dental doesn't seem to be the priority, which is understandable when you have other things. Or, but yeah, as you said, doctors and dentists working together is great for like kind of holistic point of view for patient-centered care with our children.
And just taking you back slightly to the sort of oral injuries, and I know when we sort of have children who've had non-accidental head injuries, they get an ophthalmology review to have a look for retinal hemorrhages. They will have a CT head, they'll have a skeletal survey, and we might have a look in the mouth and have a look at the frenulum. But I don't think it's ever something that's occurred to me to sort of think about dental injuries, largely because many of these children don't have teeth yet. But is that something that we should be thinking about as trying to build a picture of potential non-accidental injury?
Yeah, I think that probably could be of benefit. It probably would be a gold standard. We know that children who have had non-accidental injuries would be likely to potentially have intraoral injuries, including teeth. I think from a perspective of if as a kind of medical non-dentally trained professional or a lay person, if there are injuries which are kind of obvious to you, then that probably should be raising concern, as opposed to kind of more discrete injuries which perhaps we would pick up near the time of an injury. So I think if there's something that is acute and obvious to a non-dentally trained professional that hasn't been flagged with an A&E on that attendance visit, then perhaps that should start to arouse suspicion.
Yeah. And I guess the other sort of thought in my mind about child protection and issues of neglect is the child I see who's coming with something else, I don't know, fallen over, bumped their head, and you open their mouth and they've got horrible rotten teeth everywhere. Other than sort of flagging them to go and visit a dentist or have you got a dentist, I mean, should we be raising this as an issue of potential neglect, do you think?
Yeah, it's really difficult, and it's something that even as specialist paediatric dentists, we kind of can grapple with. BSPD have said that dental neglect is a kind of persistent failure to meet child's oral health needs when parents are aware of them, and we think that that's likely to cause a serious impairment to their kind of oral or general health. Dental decay can do that, especially when it's affecting multiple teeth. I think it needs to add to your general picture and concerns that there may or may not be about this child. I think flagging them to or kind of signposting them to a general dentist is appropriate. And if there's any correspondence with their general medical practitioner or a health visitor or school nurse, and flagging that you noted it. Things that kind of would be of concern to us would be repeated episodes for swelling or pain, failure to engage with dental care. As I mentioned earlier, if a lay person is noting that there's multiple decayed teeth and perhaps infection, then that's of more concern that it's obvious to you without dental training. So I think signposting, I think we have to take a supportive approach as possible, because we understand that access to dental care isn't always easy at the moment, and that there can be long waits or issues with accessing care in terms of going to see a general dentist. And families we see often have tried for, at length over a considerable period of time to see someone. But I think really, as our medical colleagues, stressing the importance of it and signposting them in the right direction is helpful. And that's potentially where working with your local colleagues, so that there's so for example in Yorkshire and the Humber there's been some flexible commissioning to so that we're able to signpost patients to practices which are accepting new paediatric patients. And so everyone will work in different locations, but if you had something like such as that available to you locally, then having that list in the emergency department might be really helpful, because you can not just suggest that they see a dentist, but you can give them a good idea of who they could ring with a better chance of being able to be seen.
Absolutely. Yeah, because there's no point me saying, oh, you knew to go and see a dentist if I can't then signpost them to somebody that they can see. And I guess that sort of raises another sort of slightly interesting issue, is that I know on my electronic patient record when a child comes in exactly who their GP is. So if I've got concerns, I can contact the GP, or I can send information onto the GP. Actually, I have no idea who their dentist is, and no idea of realistically, unless the patient tells me, oh, it's so-and-so at so-and-so, how to get in touch with them to say, look, I'm a bit worried about this patient. So there's maybe something that we can do better to work together better.
Yeah, that is definitely a kind of long-standing frustration, is that we sometimes struggle to either have access to or be within the same systems. We do try and work quite hard with our general medical practitioner colleagues to link in up the information that we send back as much as possible. But yeah, I think it would be beneficial to be able to link all of that together.
Perfect. So just to round things off then, this has really opened my eyes. There's so much stuff here that's really interesting. If there was one kind of message that you guys wanted to get across to us working in paediatrics or PZD, what would it be? And I realise I'm slightly putting you on the spot there.
Well, perhaps we could have one each. I suppose mine would be to put importance on dental health. So trying to encourage families to consider that it forms part of your overall health. So definitely our paediatrician colleagues to kind of ask the questions about dental health and seeing a dentist, so that it's deemed to be something that's of significance with families rather than an afterthought.
Yeah, because when health visitors go in after a child has been born, they do, especially at home, they do talk about dentistry and are you registered, and they have oral health promotion packs and things. So it's starting to move that way. So it's just continuing that as the child gets older.
And then I think my other thing, if I'm allowed to, would just be about simple messages from our medical colleagues about prevention. So really simple things like brushing twice a day with a fluoridated toothpaste that's spat out and not rinsed.
Don't rinse. Yeah.
And reducing the consumption in terms of frequency of sugary foods and drinks, with plain water and plain milk being the only two safe drinks.
The best thing in between foods. So we always say kind of juice with meals if you want, and kind of water and plain milk in between to give your teeth a break. And I think if we can repeat that
quite simple messaging,
yeah, then that would be really helpful.
Absolutely.
I was just going to say about trauma, just to kind of, that if a patient comes in with dental trauma, don't panic. And part of your asking your questions is asking if they've got a dentist, which hopefully they do, and if the tooth has come out, to try and pop it in, or pop it in milk straight away.
Perfect. I know I said that was the last question, but you've just prompted me to put one more question about rinsing and spitting. Why shouldn't you rinse?
So so I suppose an analogy would be that you wouldn't be likely to put an ointment onto your skin and then wash it off straight away. So the same kind of thought with toothpaste, really, which is that you brush your teeth, you do a lot of good for your gums with the kind of mechanical action of brushing, but the other benefit is that you use a toothpaste with fluoride in it, which helps strengthen and protect your teeth. So if you do some vigorous rinsing with water afterwards, you're essentially spitting that helpful fluoride down the sink. So it takes a bit chalky to start off with, it takes some getting used to. The message is the same for the whole family, a good spit out and no rinsing.
Perfect. Right, that's great. I really like that. So we need to start putting the teeth back into the body.
Yes,
we do,
please.
indeed.
I like that. So thank you so much, Jessica and Lucy. I really appreciate your time. I'm sure that'll generate lots of interest and lots of discussion on social media. But for now, thank you very much.
Thank you.
Thanks for taking the time to download our podcast this week. If you enjoy our podcasts, please tell your friends and colleagues, and subscribe to us on Spotify, iTunes, Google Podcasts, Amazon Music, and of course our SoundCloud. Thanks for listening.